Reverend George Hanso is the Director of Health Services Research and Quality of Healthcare Chaplaincy at the Healthcare Chaplaincy Network, Incorporated, and has been part of the organization for more than 3 decades. First as a chaplain at Memorial Sloan Kettering Cancer Center, and later as an esteemed member of the chaplaincy's management team. He is a board-certified chaplain and the co-principal investigator of a research project funded by the John Templeton Foundation, which will grow the field of chaplaincy research in palliative care. And I'll just say that George, more than any other person I know in chaplaincy today, has pushed us as spiritual caregivers to take research seriously. In fact, I have his resume in front of me, and there are 3 or 4 pages of articles that George himself has published, studies that he's done in the field of spiritual care. We've not often taken that ourselves seriously enough to do that and say we need to be research-based. We need to be saying, does this work? Why does it work? How does it work? He is an ordained ELC pastor, and last year the Association of Professional Chaplains, where he has served as both president and national chair of certification, gave him its highest honor, the Anton Boysen Professional Service Award. Will you join me in welcoming George Hanso?
Let's see. Usually I have to adjust things after my boss gets done here. You know, everything, the mic has to come down and stuff like that, but he did it without it. So, good afternoon. Now, I get the after lunch speech, which I take as a badge of honor. And I'm glad to see all of you that I can see at least look like you have your eyes open. This is a good start. And I also applaud you for your courage in inviting 2 senior managers from the Healthcare Chaplaincy Network in one conference. It's a little much for me, usually, and I work in a place where I'm at the end of a hall, a physical hall, and every once in a while, the guy you saw here this morning manages by walking around. And so he comes and stands in my door to my office. Now, you can imagine when that happens, there is no going away. There is none. So you have to deal with it. So, and I'm a New Yorker. All my life, I have never in my life lived more than 50 miles from Manhattan. I've never lived in Manhattan, but I've lived no more than, and that includes college, seminary, you know, whatever. So I am an unapologetic, absolutely unreformed New Yorker. I'm a Jersey boy, actually. And I'm a product of a mixed marriage, and those of you who are Lutherans will understand this. Like me, my mother was German, and my father was Slovak. Now, we grew up in the German church because my father was the one who decided that he would go to any church at all except if it was Slovaks, because he might run into one of his relatives. So he wasn't going there. And in fact, when I moved to Greenwich, my father grew up in North Jersey, I went to, there is a Slovak Zion church in Greenwich, and I went there, and the pastor knew all of my aunts and uncles. I thought, that's it. We're leaving, you know, that's it. I'm going to the German church. So we all come from, in this country, I think the speakers today have made the case nicely of what cultural diversity is. And I live in New York, so I speak very little Spanish, Yiddish, Arabic, what else? That's patois, Haitian patois. But mostly my Arabic basically runs to Assalamu alaikum. And does anybody know the response to that? Very good. Assalamu alaikum means peace be with you, and also with you. See how that works? You know how to do that in English, right? So that you're just now doing it in Arabic. And I think, you know, the point that we're going to talk about today is there's cultural sensitivity. And we talk about cultural sensitivity instead of, we've stopped trying to use the term cultural competence. Because I think authors have made the point, and I agree, that we can never be culturally competent. It means that you have mastered all there is to know about this subject. So think about that. It's certainly not going to happen in New York City, I will tell you right now. One of the hospitals that we serve is New York Hospital Queens, which is in the Presbyterian system, and they're in Flushing, which is where LaGuardia Airport is, and Citi Field, where my beloved and totally incompetent Mets play. And in the hospital, the signs in the lobby are in 9 languages. 9. Try to count what 9 is going to be and see how you get to it. And none of those groups have more than 30 to 40% of the population. So in 4 blocks from the number 7 train station to the hospital, it's Chinese. All the signs are in Chinese. Then they switch. There's an Indian and Pakistani section that is a couple of blocks. And then it switches to Russian and Yiddish. This is walking down the same street that takes 15 minutes from the subway station to the hospital. So you can't possibly, now we're fortunate that we have staffing that place in terms of chaplains, an Orthodox rabbi, a Korean Presbyterian woman, and a Roman Catholic Chinese woman who speaks 3 dialects of Chinese. So we're doing pretty well on that one, but it's still, there's a lot that they don't know. So cultural sensitivity is what we do. Just let me say a little bit about, people get confused about what I do, because I am a chaplain. Been a board certified chaplain for 30 plus years. And if you stay a board certified chaplain, they make you some office and then they give you an award. And the only beauty of that means that they can't nominate you for anything else because you're done, you know. I've had all the jobs already. So I'm done and I can complain all I want, and I do, and they can't, there's nothing they can do to me. So this older stuff has some advantages. But as Scott said, we've come to a place in the healthcare chaplaincy, and I've come to a place in my career where somebody, and not all of us, but somebody has to get to the place where we have evidence for the efficacy of chaplaincy that we all know, and spiritual care that we all know is there. But it's no longer the case that just saying, I mean, I know a lot of very good healthcare administrators who really believe in spiritual care. They do. But they say to me, George, I can't do it. I need an evidence base. I was in Washington last summer, and there's a congressman from Northeast Ohio who has written a book on meditation, actually, and he started to appreciate spirituality when he watched his grandmother growing up say her rosary, and he realized that after she said her rosary, she was a lot calmer than before. And that's how he got convinced. But I said to him, you know, you're so behind us, why can't we get a hearing on the Hill? And he said, you show me the science, and I'll take it to the Hill. So that's what we're about. And we have this little conference next week, which, by the way, if you want to get a virtual, it's being simultaneously streamed. And if you still have a chance to buy, $400 gets you a streaming video for 3 days of solid, if you can stand it. We're reporting out 6 studies that came from this Templeton project that are all have a researcher and have a board certified chaplain on them. So first time we got these chaplains on this research. So anybody that still is interested, there's still time. My registrar will hate me because she's swamped, but there we go. So I'm doing this, and also a quality improvement. I think, you know, we have to get better at what we do, and cultural sensitivity is part of that. So here's some of these things. I'll try to tell you what are somebody else's work, and so you have to take it seriously, and what's my work, and so you can disregard it if you want to. This is mine, but I believe, you know, I don't know about others of you who went to seminary, but when I went to seminary and took preaching, and I didn't learn much about preaching, but they said to me in my good New England seminary, there are 3 points to a sermon. Does anybody know what the 3 points are? Can you tell me? You tell them what you're going to say, it, you tell them what you said. So this is all 3 of those points right here. And this is the end game for me. This is what this is all about. As Eric suggested, this is about creating a healthcare institution where patients, family members, and staff can live out their spiritual and religious beliefs, values, and practices within the bounds of mutual respect and safe healthcare practices. So, you know, there's some things that they can't do. You know, I had a family who wanted to, you know, come and bring a chicken and kill it and swing it around their head on the pediatrics unit at Memorial Sloan Kettering. The risk management people and infectious disease were not happy. So that didn't happen. So there's some limits, and you have to be clear about what those are. There's a new mindset. When I came into healthcare, there was it was a risk avoidance mindset in administrators. So I went in one day in the early 90s to my administrator at Memorial and said, we have a new resident, and we have a significant, and Memorial had and still have a significant Orthodox Jewish population. And I said, you know, we've accepted, here's our resident class, CP resident class, and this guy, Yusuf Hassan, is a African-American Muslim. She knows that we have them assigned to units and they visit everybody. And she looked at me and said, you're out of your mind. What is going to happen the first time he walks into the room of an Orthodox woman and introduces himself as Imam Hassan? All hell's going to break loose and it's going to wind up down at my office. I said, fear not. We did a good job. Now, bottom line is, he's still at Memorial. He's been on the staff. He took my job as pediatrics. Some of you know Imam Yusuf Hassan. He's about this big. Was the first Muslim to be board certified as a chaplain in the world, I think, certainly in this country. And he hasn't left Memorial ever since. So I was right. But she had given me a lot. So that mindset is now gone. I think today it would be about why not, and what do we have to do to meet the cultural and needs of our, not only just our patients, but also our employees. We want to retain employees. So that means, how do we accommodate the cultural and religious and spiritual needs of our employees? So for instance, in our places usually, I don't know about yours, we have significant Muslim employee base in New York. And during Ramadan, we put out, chaplains usually put food for them to break fast. So they come down and they take 10 minutes, they break fast, they make their prayers, they go back to work. Otherwise, they're going to go out of the hospital, they're going to look for a mosque, they're going to be gone for an hour, because they are going to do what they have to do to break their fast. They are. So, and the employees feel like they're really cared for. And it's how much does it cost? It costs nothing, nothing to do. And sometimes families will come too, of course, but it's really not just about that, but it's about employee satisfaction and retention. Doesn't mean knowing. It's a respect for differences, and this point's been made already, and that there are many ways of viewing the world that are, yeah, I don't know why they put mine on full pages, and my boss got the small one. I'm going to tell him about that at some point, point that out to him. But it is about willingness to accept that there are other ways of viewing the world. and our way is not the only way. And it's not about right and wrong. So ethnicity, just to run, a group of people whose members identify with each other. This is just, again, these are definitions I've pulled off Wikipedia, I think, just to kind of, they're not necessarily the definition, but they are a way of kind of, I'm big on, we need to be clear about our language. And if we use ethnicity, culture interchangeably, we get into trouble because they're not the same. And we need to at least have some definition of what they are. So this is mine for ethnicity and culture. A learned or shared knowledge, beliefs, traditions, customs, rules, arts, history, folklore. And it's how we interpret experiences and generate social behavior. So cultures are cultures. And so as I said, I grew up in a European household, and punctuality was highly valued, which makes me a good fit for healthcare, because one of the values of healthcare is that we value punctuality. And oh, by the way, there's a healthcare culture that has its own values that we need to take into account. So some years ago, my wife and I were invited to a wedding of a Lutheran pastor colleague who was being married to a woman from Jamaica in a Lutheran church in Brooklyn. And we arrived there, being good, punctual people. We arrived there 15 minutes before the service, thinking that was the right thing to do. The church was black. There was not a light on. There was not a soul in there. Not a soul. I panicked. I thought I was here the wrong day. And so we waited. And about 45 minutes, half an hour later, the florist came in, and another hour, and a few wedding party people came in, and 2 or 3 hours after the appointed time, the wedding happened. It's, the Caribbean approach to time is not mine. And nobody was bothered, and I tried to behave like I wasn't bothered. I knew that much. I told this story to a colleague of mine who grew up in an Orthodox Jewish household in Brooklyn. He's now conservative, and he told me a story of the first time he went to a Christian wedding. And he got there 20 minutes late, after the hour, not late in his mind, 20 minutes after the hour, thinking he would be early, only to find that the wedding was half over. And people looked at him like, what's wrong with you? So Stefan has a book outside probably called, if he doesn't have it, it's Skylight Press, it's 2 volumes, How to Be a Perfect Stranger. And it's really wonderful because it tells you about these things. Is it out there? It's great. It tells you about, should you bring a gift? What gift should you bring? Should you stand up? Should you not stand up? So it's great. So that's culture. Spirituality, and this is, excuse me, I'm also fighting a cold, sorry. Spirituality, this is a definition that comes from the National Consensus Conference on Spiritual Care and Healthcare. And I use it mainly because I like it. And it is a consensus definition. So there were about 50 people in the room when this was written. And there are people of all faiths, and psychiatrists, and chaplains, and clergy, and social workers, and nurses, and doctors, and spiritual directors, and it's a Buddhist priest from Santa Fe. And we spent an hour and a half, and we actually agreed on this. It was quite remarkable. So it is a consensus definition. It's now been taken up into the National Consensus Guidelines on palliative care for North America. And we hope that the next step is that it will be adopted in the next version of the Joint Commission standards on certification in palliative care. But a lot of the things that you see in this are, let's see, do I have a pointer? No, apparently not. Is that you hear a lot about meaning and purpose. You heard Eric talk about those this morning. and connectedness. And those are some of the terms you see in spirituality. It's about connectedness and about where you find your meaning and where you find your purpose. So if you see definitions of spirituality, pretty much all of them have that in it. So the first thing to do is to see what our predispositions are. And as I told you, I found out about how uncomfortable I was with lack of timeliness, which my daughter-in-law has, because I get to airports, you know, like 2 hours before the flight. My daughter-in-law gets there 2 minutes before the flight. So she's branded this Hanzo time. It's been one of the biggest adjustments in her marriage to my son. So it's, what are our predispositions? You know, so like, what causes illness? Again, we think, well, okay, we all understand what causes illness, but do we? Do we all agree on what causes illness? I mean, I've got a cold now, and I'm running a monster conference next week, monster conference, on which the future of, if you ask my boss, the future of the healthcare chaplaincy rests. And on which the John Templeton Foundation has invested a cool $3 million, which I have successfully spent. Piece of cake. So no pressure about that. So is this cold stress related? Is it the fact that I have spring allergies characteristically, and spring has finally sprung where I live? I don't know. I mean, you know, I want to say it has to do with allergies because I can deal with that better, but who knows? What does it mean to be a good patient? In my Northern European culture, it means shutting up and being stoic, especially as a man. In many cultures, it has to do with making your pain very, very clear. And we don't like that in healthcare. We don't like the loud patient, but it's their culture. How do we treat illness and injury? Who do we go to? I grew up next to my maternal grandmother, next door, across the lawn. And that was where we went when we were sick. And she proclaimed what was to be done about it. And what we were to, you know, drink and eat, and when we were to go to the doctor, and all of that happened. So that was the way our family was. And, you know, think about your family. And what was true in your family in terms of, or is true in your family, in terms of how you go about that. So attitudes, and again, you know, this pushes the limit because a lot of us get involved in healthcare and what's the bounds of what we can do. And so is it whatever works for the patient? So think about that for those of us who are chaplains. If it works for the patient, is that okay theologically? Whatever? So I will admit, the time I spent at Memorial, I'm a peds chaplain, to confess. So I covered pediatric oncology at Memorial Sloan Kettering for 23 years. There's something wrong with me, but I decided not to find out what it was because it probably would ruin my career. But I had a mother one day who had, she kept saying, well, there's going to be a miracle. Her son was dying. Her 4-year-old son was dying. And she came from kind of fundamentalist Christian background, and she kept saying, there's going to be a miracle, there's going to be a miracle, there's going to be a miracle. And the staff was saying to me, you got to go tell her there's not going to be a miracle. And I would say, well, stop. You know, I'm the one here who believes in miracles, remember that? So I'm not the one who's going to go do that, just not. But then one day I came in and they said, well, she's all of a sudden changed. She's calm. Well, I don't know what happened. I think she had a psychotic break. Maybe we're going to get the psychiatrist. And I went and I talked to her and I said, you know, kind of what happened. And she said, well, I realized that I was being selfish. And God has a plan for my son. And it's bigger than anything I can imagine. And I just need to put my son in God's hands and I've not been trusting. And she was, I could tell, I mean, this wasn't false, you know, rationalization. She was really believed this. Well, I don't believe it. I didn't believe either one of them. So what? So, I mean, what do we do? So what is wrong? How do we define wrong? You know? Is it wrong for somebody not to get treatment? Now, Memorial, that was clearly the case. Anybody who wanted to stop treatment was, you know, wrong. And how often does that happen in our health systems? How often do we think, gee, or somebody on the team says, well, that's wrong, they're wrong. Well, really? You know? Amy Berman, I don't know, do any of you know Amy Berman's work at all, or have seen her around? Amy Berman is a project officer at the Hartford Foundation in New York. She's also a nurse. And about 4 years ago, she was diagnosed with inflammatory breast cancer, metastasized to her spine, stage 4, incurable. She opted, they were going to, you know, her doctors, she went to the best doctors, they were all going to give her chemotherapy. And she said, well, I'll take a little bit, but no. And they were outraged that she wasn't going to take their stuff. And so she's been a poster child for palliative care now for 4 years. I saw her a couple weeks ago in San Diego. She looks great. And she's been on all the talk shows. And she feels great. She climbs mountains. She's in her 50s. She kayaks. She takes some medication, of course, for her symptoms, including a little mild chemotherapy to retard the cancer. But she's great. If she's taken chemotherapy, she'd probably be dead now. And by her calculations, she saved herself and the health system about $1.2 million. So was she wrong? Clearly. I mean, in my mind, no. It worked. So, but the health system culture is you need to accept all the treatment we can give you. And that's not what it is. So, okay. Aspects of culture, and Scott said I was going to talk about assessment. So this really is about assessment, and I think everybody has said, I heard Gilberto and I heard Eric both talk about how, you know, they're individuals, and, you know, we need to know what the general beliefs of different cultures and religions are, but we also, you know, there's things you need to know. I mean, I need to know that when I meet a woman with a hijab, or with her head covered that she's an Orthodox Jew, I do not put my hand out to shake her hand unless she reaches out to me. I just do. I need to know that because it would be embarrassing to this woman if I reached my hand out. And so there's certain things you have to know if you work in certain cultures. But it's all about assessment, and there are, you know, aspects of culture. So knowledge and comprehension is one, and that's clearly there. But attitudes, and I've talked about being open to things, and that's there, and skills. And there's also individual culture and organizational culture. So this is actually the 4: facilitate, provide, care, advise. Anybody recognize that? Any ex-military chaplains in the house? This is these are the 4 parts of a active duty military chaplain's job in the United States. So they facilitate food, worship, prayer. We provide worship to those who are of our group. We care. That's where most of healthcare chaplaincy works, not so much in the active duty military. And advise our administrators. So I think that applies to us. You know, we should be advising our healthcare administrators on how we treat different cultures, how we do things in the institution. This is what I said about the healthcare culture. So look at this and see if it makes sense to you. This isn't mine, this is somebody else's. But you see, Beliefs. They have beliefs, standard definitions of health and illness, the omnipotence of technology, right? Everything can be solved with another MRI. Practices, maintenance of health, prevention, habits, charting, right? You didn't chart it, don't chart it, didn't happen, right? And that's just a part of healthcare culture. You know, this is not an oral transmission culture. Many cultures are. This is not. Likes, promptness, neatness. Now, again, think about how patients become disliked in our healthcare culture. They show up late. They don't seem to have any regard. They're, in the healthcare system, regarded as not caring, not respectful because they show up late. They are not compliant. They don't think about taking their medicine necessarily. And they are not deferential. They don't seem to abide by things like hand washing. And I think we've gotten rid of the limiting visitors and visiting hours, but there's still some of that. But this is our culture, and we have to recognize it. So here are the aspects of culture, and this is from some of the stuff that Eric has said is on our website, and you can download it, and you're free to use it. I will only warn you about one thing about it. If you write to me and say, gee, you don't have any material on my culture, blah, 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 or my religion, I will write back to you and say, great, we'd be happy to publish something that you would write. I will, because we don't put anything up there that's not written by someone from that religion or that culture. We don't. People have responded to that, but just be warned that that will happen to you rather quickly. So, sense of self and space. Is handshaking done? Is it bowing? Communications and language. I am a direct communicator. It's my Northern European heritage. And I have to be careful. And I live in New York, where direct communication is valued on the whole. I had an argument with one of my colleagues who is from Southern California but lived a long time in Missouri. And he got very angry at me because I would sit at board meetings and cut people off before they'd finish their sentence. And he admitted that he cannot to this day talk and think at the same time. So he leaves a gap, and that's what he considered respectful, until one day we went to a conference about this, and the guy was saying, in some cultures, it's respectful to finish somebody's sentence for them. And that's considered that you're paying attention. And I said, see? I told you. So stand on the street corner in New York in some neighborhoods and listen to what happens. And if you think you're going to finish your sentence, you're just dead wrong. It just isn't going to happen for you. So, but that's what I am. So I need to be careful. My wife came from a family of very indirect communication, and she likes the direct better, but it's still jarring for her every once in a while when I say, we're not doing that. That's a mess. Whoa. And so it is two different things. So in other words, in indirect communication, meaning is found around the words, not in the words. I use words very sparingly and very directly. Indirect communication, it's about what's between the lines, what's between the words. Dress and appearance. So we are a dress for success culture. I grew up in the New York City area where things are fairly formal. I grew up in a healthcare institution, Memorial Sloan Kettering, which is, I always called the IBM of healthcare, because this was pretty much standard wear for me. When I left Memorial, I started buying sport coats and shirts that weren't blue or white, and non-striped ties, because at Memorial, that's what you did. I mean, especially I was a department head, and that was the culture. It's still my older son lives in Los Angeles and works for a fairly new 4-year-old startup in a techie field. So he goes to work and he's like the COO. He goes to work, button-down shirt, but the ripped jeans, the sneakers, usually yellow or something. And I've stopped because his boss does the same thing. So, but I have to think. I get gigs in Southern California because everybody knows that I'm cheap to go to Southern California, because especially now that I have a granddaughter there, and all you need to do is pay a plane fare and I'm there. So it's very cheap. But I don't take my suit. I take a sport coat maybe, and maybe I take a tie because I usually don't wear it. I gave grand rounds at Cedars-Sinai, which is one of the big hospitals in Los Angeles. And I wore a tie because I just couldn't stand it. I was so uncomfortable. But I think I was the only one in the room with a tie. I was full of physicians. But I had to. I was just too self-conscious without a tie. But I wore the sport coat. Eating. Again, we know that eating is a ritual in many places, and you don't, it has some very important aspects to it. And here, I eat for sustenance. My wife, in the family I grew up in, often we did not sit down to eat at all. I mean, we just didn't sit down. We ate standing up. And it makes my wife absolutely out of her mind. Until she thought it was me until she saw my brother do it. And so it's like, why would I sit down? Why would I use a plate? I stand on the sink, it saves plates, I'm done, and I go. What's the problem? I don't understand it. But that was what my father did. But it wasn't about eating as a social experience, clearly. So, and of course, religious rules apply. So if you eat in a home of observant Jew, for instance, there are rituals before every meal. I had to learn, one of the things I had to learn, and it took me years actually, one of my dearest colleagues who just died about a week ago, Pesach Krause, was a conservative Jew. And so he would bring his tray in the cafeteria, put it down on the table, and then he would, of course, go and wash his hands. And until he had washed his hands and come back and eaten the bread, he wasn't going to talk to me. But I took a long time, and I knew this. I knew it. But I kept talking to him anyway. I think I eventually learned it, and he was very gracious. He was a wonderfully gracious guy. But he would smile at me, and his mouth was going, but it wasn't talking to me. He was making his prayers before the meal. And it was about those religious rules that he was just going to observe, whether I was smart enough to get there or not. And I wasn't for a long time. So this is the one that's harder for me. I'm a absolutely linear thinker. Absolutely linear thinker. I was trained as a scientist. And I go connect the dots, point A to point B to point C to point B, which makes me a great grant writer, actually. Because, foundations want to see A, B, C, connect the dots. It's great. It's not so great if I have to try to understand somebody I've supervised people over time they were not linear thinkers, made me crazy. Crazy. I had no idea what they were talking about. And they were talking English too. I just didn't, because I just don't know how to follow nonlinear thinking. Nobody ever taught me that. But it's, you know, a lot of people do it. So there's time spent enjoying relationships. Again, relationship with family, friends, responsibility of self. We had a case at Memorial some years ago that actually Yusuf Hassan and I were on, and this man was admitted who was in his 50s. He was single, worked for the post office. He was admitted with really late-stage lung cancer. I mean, there was even Memorial wasn't going to treat him, and they'll treat anybody. So we were trying to get him. He was in tremendous pain. We needed to make him DNR to get him to hospice, but we were afraid that you know, we couldn't give him pain med. We thought he might stop breathing. He was so bad. And but there was a sister there, and they couldn't. The sister, they would go in and talk to the guy, and he'd agree, and the sister would go back in and talk him out of it. So Yusuf and I went up there, and we scoped the situation, and we realized that this family, there were 8 siblings. This guy was the youngest. And they made healthcare decisions. When any one of them got sick, the healthcare treatment decision was made by the 8 corporately. So no decision was going to get made until the 8 had assembled. And they were coming by car from Oklahoma, Illinois, Kansas, and South Carolina. And we had to tell the irate house staff, you were not, it's just not going to, just get over it. Get used to it. This guy's going to be the way he is until they get here. That's it. Sorry. The sister is not going to allow it to happen. She is not. Because she'll have to be accountable to her siblings when they get here. And when they got there, Yusuf and I walked in the room, and Yusuf is about this big. And the oldest brother, who was clear was the oldest brother, had a tractor cap on it, said, you know, Jesus is Lord. And Yusuf, who grew up in Alabama as a Baptist, I hear him whispering, saying, because you know, we all talk to ourselves. He goes, "Oh Lord, we're in trouble now." But once the family got there, we got the hospice nurse in, and they agreed to take this guy to hospice. So it was fine, but we just had violated their structure about how this was going to work. And the family was the family, and it wasn't going to work. And the same thing is true, you know, we have trouble with people who don't believe, only North America and Europe basically believes in individual autonomy. None of the rest of the world does. So, you know, we get these people like, Mrs. Chan, who you go and you say, "Mrs. Chan, we need you to sign this. My son signs." Well, no, you have to sign. No, my son signs. And they come out and they say, "No, we can't." I said, "She'll sign when the son comes and tells her to sign, not before." "Well, but that's a violation of her rights, and we need to talk to her about that." And I said, no. So again, the healthcare culture and the US culture in which we come from says individual autonomy trumps everything. Well, that's not true in many other cultures, and we have to understand that that's not necessarily right. So values and norms, I've talked about some of those already. Beliefs and attitudes, you know, we're very egalitarian in this country. We believe in equality of gender. Well, not everybody does. And, you know, it's not our job to change these, you know, cultures, Muslim culture particularly, to say that, you know, women should, or Orthodox Jewish culture, to say that women should, you know, be equal to men in worship. It ain't gonna happen, first of all. And it's not their problem. They don't have a problem with it, we have a problem with it. And it's hard. And we respect authority and social order. What did I do? Yeah, work habits. You know, I'm an achiever. I score off the charts on the achievement. I got to check off 5 things a day that I've done. It's a European value. CP failed miserably to teach me about process. And I can call some CP supervisors' names I'll give you who will attest to that fact. And, you know, and work habits, again. So, again, you know, keeping the Sabbath, death and dying, you know, how do we, and how is medical information communicated? And, you know, it's okay that some families are going to say, Mrs. Chan is going to say, you tell my son will tell me, or not. We're not going to say that, but that's what it amounts to. And we have to say, well, you know, that's her choice. And, you know, if we're in a culture now of patient-centered care, if we really believe in patient-centered care and the patient really says, I don't want this information, you give it to my son, to my husband, whatever, that's what they want. And there's nothing wrong with them or what they want. So again, here's another one. This is kind of tripartite thing from my colleague, Larry Burton. And one of the problems we have in healthcare is most of us are negotiators. We're negotiators in our faith. We believe in Scripture, but we also believe that we should interpret Scripture among us, you know. We have a lot of people who are what are called traditional thinkers. We call them conservative thinkers. And the authority is totally external. So again, you know, my pastor decides, Scripture says, the imam decides, the rabbi decides. That's it. That's it. It's the way it is. And it's also, again, terribly frustrating for healthcare people because we try to negotiate with them. And we fail because they're not going to negotiate. Yeah.
Tell me if it's appropriate. The case about the Scheibels, about the couple who
Right.
lost 2 children.
Terry Schiavo we're talking about here. There was lost 2 children? I'm sorry.
They lost it because they didn't believe in healthcare.
Right. Well, see, that's, again, the whole issue of immunization and children is, again, where we have to decide what are the limits in our culture. You know, and where do we have, where does the culture, where does the society have a duty to protect children, to protect people with mental illness or mental deficiency who, you know, cannot make a decision with themselves. That's different from Mrs. Chan, who has all her faculties. She knows exactly what she's doing, and she's okay with it. That's a different issue. But then where does the line go? You know, I have chemotherapy, and we had teenagers on the unit, and the underage, and if a teenager said, I'm not taking chemo, you know, the staff would say, well, we got to make them. And I said, this kid's 6'2", and who's going to go out and strap him to what gurney and bring him into this hospital to pump chemo in him? Come on. What are you going to do? So, I mean, you really have to play this, you know, where does that go? And I think it's a very tricky business in many ways. But, you know, immunization is a good example.
Because my church, a member of my church is a Scheibel and has 3 other kids. And
Right.
The Department of, you know, Health is right on there, making sure the kids are getting their appointments. And,
Right.
you know.
Well, and there's a lot of, we've had outbreaks of measles now in this country because a lot of people are not getting immunized. So it's not just an issue for those kids, it's an issue for the population as a whole. So it's all about assessment, okay? This is the message at the end of the day. It's all about assessment, it's all about assessment, it's all about assessment. And, you know, you have to do the whole story, and somebody has to document it in the record so the team knows it. And you don't have to document everything. So, you know, some people don't have, you know, a daily religious ritual. Fine. Some people, you know, modesty is not an issue, although for most people it is. but you know, daily religious observance. I got a call one time from a nurse. It's going to stop. Got a call one time from a nurse saying, you got to come up here. We went in to get Mr. Jones, who was an elderly Orthodox Jewish man, for surgery, and he's facing the window. He was davening. He was making his morning prayers. And she knew that this orthopedic surgeon was a real pain in the butt, and he was literally, had been known to leave the operating room, break sterile contain, and come upstairs and yell at the nurses when his patient wasn't down there. So they were shaking in their boots. Now, that could have been prevented by good assessment. They should have known that this guy that should have been in the notes, it should have been documented, and they should have known. But they didn't. So, again, you know, what is healing? Eric talked about this a little this morning. What does it mean to you? What does it mean to your team? What does it mean to your families to be healed? I'm going to stop. And then, you know, accommodations. How much do you accommodate for employees particularly? What's an accommodation? Or what do you say, well, no, this is something you have to do on your own time? And again, you know, we have dress, food, daily religious observance, holiday observance. So this is one of the things, the last point I'm going to make, and then I'm going to stop, because I've already gone over what I intended. One of the things is that this is not about the golden rule. I still hear people saying, this is about the golden rule. It's not. It's actually the worst thing you can do is assume that cultural sensitivity is about doing unto others as you would have them do unto you. Bad, bad mistake. Because people are different than you. I know that's a shock in some very fundamental ways. Different and different. And it's not about you. So this is a book, Joint Commission publication. You'll see it in your slides. Online, there's Joint Commission standards for those of you who have to do Joint Commission stuff. They put in a lot of new regs a few years ago that Sue Wintz and I were privileged to be part of writing. And that all is just to show you what's in there. Okay, I'm going to stop. Questions? I got a few here, a few minutes.
George, if you would repeat the questions for the sake of the
Yes, I will. I will, thank you. Good reminder. Okay, now you got a chance to ask questions. Come on, folks. I know it's after lunch. Yes?
Sorry, I missed the first few minutes, but can you address or define LGBT or disability issues as cultural?
Yes. If you, I haven't, but the Joint Commission has. I was telling Ann Huey, are you still here, Ann? This morning, because she asked me about this, if you look in what about LGBT issues? And disabilities. In the roadmap, in the stuff in the Joint Commission standards, you can hear the LGBT voice very clearly, and the disability voice. They were clearly at the table and made their voices heard. So, those standards go through the stages of treatment. So it's admission, assessment, treatment, end of life, blah. So there's lots of stuff about partners in attendance, and I would say that's the best source I know. There's not research, as far as I know, but it's clearly gotten into Joint Commission standards. Yeah?
How do you navigate between your role advocating for the patient and your place of employment?
Right. Good question. How do we navigate between advocating for the patient and your place of employment? Well, I think, first of all, you need to have a good relationship with your team. Because if you come busting on the floor and out of the blue and say, you got to do this, you know, it's a waste of time. You're not going to get anything for the patient, and you're going to be thrown off the floor. So I think it starts with having a relationship with the team where they trust you to represent this voice. And then it's a question of, you know, a good assessment. You know, you know, anybody who's been a student of mine knows you don't come into my office. There are two words you don't use. I believe or I assume. Bad. I'll send you back upstairs. You need to know. You need to be able to say, the patient said to me X. I asked the patient about their, jewelry. And they said, this is Baba. So, and that's the way you document in the record. I think that's the, more concrete, the more concrete you can be, the better off you are, I think. And that's how you advocate, by presenting what the patient tells you. But they only tell you if you do the right assessment. So, good question. Thank you. Next question. Oh, boy. Come on, I got to drive 2.5 hours back to Connecticut, folks. Yeah.
Why would you not ask, do you understand?
Because in many cultures, they're going to tell you yes. Why? The question is, why would you not ask, do you understand? Because they'll say yes. So what have you learned? In nursing, the nursing literature about consents, you'll see this thing called talkback, I think it's called. Anybody know what I'm talking about? I may have the wrong name. Teach back, thank you very much. Where you teach something and then you say, tell me what I just said. That's how you say it nicer than that. But that's the point. The point is you get them to repeat back to you what you've told them. And then you know. Yes is like, so, maybe they're telling you the truth. Or how do you know whether they really understand or not? Even if they're being honest with you, even if they think they understand, how do you know? You don't. Yeah.
Can I also answer that just from my perspective?
Please.
I come from, my parents immigrated from Hungary.
Right.
And they learned to speak the language. And I remember one of the most offensive things that people would say to them was, people would call at my house and go to my mother, do you speak English? Do you
Right.
understand English? So if someone says that, to me, it would be kind of like, what, you don't think I
Right.
it just would shut me off because it would be so offensive that they would assume, and
Right.
not everyone does, but it would almost like make an assumption.
Yeah, there's a huge problem in this country, and it's not necessarily language-based, with health literacy. The percentage of people who are not judged to be health literate is very high. It's way over 50%. And most of them are native English speakers. So, again, the assumption that because their first language is not English, that they're not health literate is also a mistake. That's the other side of it. So, or that their native language is English, and so they are health literate. Well, that's often wrong. I think this health literacy thing is a big problem that we have not tackled well. And we certainly as chaplains, I think, can, one of the things that I hate doing, but I do it, is go to a doc who's just spent an hour or so explaining something to a family and say, they have no idea what you just said. Well, okay, we're going to go in again, but I'm going to go with you because I'm going to listen and have you use English, that I can understand, and then we'll see how it works. Because there's a great book out on this if you're interested in reading about healthcare communication. It's written for doctors, but it's good. I think it's Mastering Communication. I can look in my, but the authors are Anthony Back, Tony Back, and James Telsky from Duke. Tony Back's from Seattle. Great book if you're interested in teaching doctors and nurses how to communicate bad news and complicated stuff. It's just excellent. And Bob Arnold is the middle author from Pittsburgh. So next, another question?
George, I have one question for you.
Yeah.
One more comment. And in supervising students, for years I used Bichette 7x7.
Right.
Model assessment. And there's a cultural component as one of the first 7.
Right.
And students inevitably would bring back verbatims and say to me, there were no cultures.
Right. I love it.
And of course, the way I understood that is when you perceive yourself as part of the dominant culture,
Right.
It's almost invisible to you.
Right.
I don't know what you're
No, I think that's right. I think that's why this list is somewhat good because I mean, it took me a long, long time to realize that not everybody was a linear thinker. And a lot of people are nonlinear thinkers and they don't have mental health problems. Seriously, it took me a long time to admit that. You know, I thought they were rambling and they were demented. I told you I'm from New York, but but it's true. I mean, you think, well, what's wrong with this person? I'm speaking English, straight English, and they're not getting it, or I'm not understanding what they say. No, I think it's an excellent. That's why assessment is so critical, and you can't miss points, because you miss something critical. And I teach doctors and teams how to interview patients. And you know, it's interesting how when they get to get onto a physical issue, they just drill it and avoid, you know, partly because that's what they do, and secondly, they avoid everything else. And we have the cases set up so that there's some big elephant that they have to ask about. They miss it. The average, you know, this is where chaplains, I mean, I'll put a plug for chaplains for a minute. The medical literature suggests that the average time between when a doctor asks a question and when they interrupt the patient is, anybody want to guess? 8 seconds. 8 seconds. It's been timed. So we just have to do that. And we as chaplains or other people who are trained to listen can and should be saying, well, wait a minute. You know, tell me more. Let the patient talk. Anyway, now I'm over. Thank you, folks.